Newton, and this is my presentation on fetal development, monitoring and intervention. Okay, so once fertilisation has happened, the process of cleavage will begin. So this is where the fertilised cell will begin to divide into different sections. Until it reaches this point, it will divide into 16 cells, and then it's called morella. So they will then form an outer layer called the trophoblast and have the cell cluster encased with an outer layer. So the clustered cells will eventually form into the embryo, and these clustered cells within are known as the blastocyst. And during this stage, they will go through a process in which the cells begin to organise themselves. The very central of these cells is a yolk-type substance, like what you get in an egg, and that is the source to the fetus's nutrients, and the blood, and also blood, and the full placenta is formed. So during this period of time, the 3 layers are formed and are known as the germ layers, and they will later develop into various tissues. And while this is all happening, the implantation of the embryo is being embedded into the uterine wall. So the next stage to occur is called the gastrula stage, and this begins when the 3 layers are formed and start to move to the centre of the blastocyst, and they will form the prime streak. So once this has occurred, the cells start to fold inwards and detach from the prime streak, and then they form new cells. Once that stage is completed, the more definite changes will start to happen to turn the embryo into a fetus. So the heart will start to form and be the first organ to take shape. Then the different sections of the embryo will then start to transform into what we recognise as the fetus. So you've got the epidermis, which is things like your skin, hair, inner ear, eyes and mouth. You've got your ectoderm, which is your facial cartilage and your sebaceous glands. Then you've got your mesoderm, which is some of your vital organs, your kidneys. You've also got muscles, your gonads, bones and red blood cells. Then you've got your endoderm, which is then going to be your lungs, your bladder, your thyroid and the pancreas. So this stage is called the organogenesis stage, and this will occur up until week 11 of the pregnancy. And from this point, this will now be a fetus rather than an embryo. So by the end of a woman's first trimester, the fetus will now look more like a baby. And moving into the second trimester, which is a 14 to 27 week gap, this will continue to develop. So such as week 15, you will now be able to possibly see what the sex of the baby is. Not always possible, but it's more than likely. The ears are then at the stage where they're nearly fully formed. The skeleton is starting to harden and the placenta will appear a lot thicker and stronger. Features including the lips and eyebrows may now be presented as well. So the fetus's skin at this point is very translucent, and however, as it develops, moving on by about week 25, it will start to change, and then the fetus will start to add on things like baby fat and start to look what we know as a newborn baby. And they also start to grow as well in length, width and all of that. So then moving into your final weeks, which is your final trimester, everything is starting to finalise, ready for the baby's birth. So there's things like eyelashes are growing, the brain muscles are developed, and the lungs start preparing for when they're born. By week 35, the lungs are now fully formed. So by this time, the due date has arrived. The baby should be fully formed, as it can be within pregnancy, but will have more growth, of course, when it is born as well. For example of this, the skull will still be soft when a baby is born, in order for it to be flexible when it's coming out of their mother, and it will just strengthen as time goes on. So you've also got psychological and sensory capabilities. So psychological ones, you've got week 6, the heart starts to beating, but by week 9 this is regulated to a normal rhythm. There's brain impulses start at week 14. They start to function facial movements a lot more. Week 16 the brain will start to function movements all over the body, and then by week 32 research shows that the fetus can dream like a newborn baby. And then you've got obviously your sensory capabilities. These week 8 sees the beginning of a touch sense coming into place, mainly within the face, but it will obviously again increase over time and as they grow. Week 15 the fetus will start to acknowledge light, and if you were to shine possibly a light on the belly, they will possibly move away. By week 19 the senses start to kick, may acknowledge sounds like music and talking of people that they're used to. Week 26 the baby will start to inhale and exhale, preparing for when they are ready for birth, and their smell and taste start to develop from as early as 6 to 7, where the receptors start to develop within the mouth. And from week 24, however, the fetus will be able to start smelling and also tasting things as well. So this is about the Doppler, ultrasound and fundal height. So first off, you've got a Doppler scan. So this is used like a bit like an ultrasound, where gel will be squeezed onto the belly and then a device will be rolled over the stomach. This is just to check the blood flow, and it is flowing correctly around all body parts of the fetus, and it can also check the heartbeat as well. A Doppler is used a lot of the time when there may be an underlying health condition or some sort of risk to the pregnancy, which means the ladies have to be monitored a lot more closely. These can occur with conditions such as diabetes, high blood pressure, small babies, or even reduced movement. Another scan offered to everyone during their time is an ultrasound. So an ultrasound is a use of sound waves to produce a picture of the fetus within the womb. So this is to basically check that not only is the fetus growing correctly, but also that the womb appears to be doing its job and it's fully formed for the fetus to grow. So although ultrasounds are a big part of most people's pregnancies, they can also detect serious situations like conditions the baby may have, and in some cases whether a miscarriage has occurred. Majority of people will be offered at least 2 in the duration of the pregnancy, but more high risk pregnancies do see that there are a lot more due to them having to be monitored more closely. So like a Doppler, a handheld device will be used across the stomach after a gel has been applied. So in some cases an internal ultrasound may be needed, but this is where it is inserted via the vagina. At week 12 the sonographer who does the ultrasound will determine the due date of the baby, and then around week 20 they may be able to identify the sex if the baby is sat in the correct position. Something else that's used during pregnancy is fundal height. It is a method used by healthcare professionals during pregnancy, which is to measure and calculate as best as they possibly can the development of the fetus inside the womb. So this is done by measuring from the pubic bone to the top of the uterus. So if the fundal height is low, it could just mean that the fetus is smaller, and they do recommend then kind of the recommended size of an average baby for the age that they are. It could be no risk at all, but it would just indicate something else like low amniotic fluid, which would mean treatment is needed in order for there to be no risk or a restriction of growth. Maybe another issue which could be addressed to make sure and keep an eye on so that it doesn't worsen over time. On the other side of this, it could be high, which again could be simply that the baby is just bigger than the recommended size. It will need to be monitored just to make sure that this does not cause issues not only for the baby but also the mother as well, and it doesn't impact the remaining pregnancy or birth. Another issue that it could be, if it is slightly bigger, that it could be too much amniotic fluid, which could obviously be a risk and cause issues later on. So, fetal monitoring during labour. So, intermittent auscultation, also known as listening. So, the midwife will use either a stethoscope or a Doppler to just listen to the fetus heartbeat and make sure they're under no stress. So, and this is normally around every 15 minutes. This is used on patients that have no risks, and it just allows the patient ease of knowing what's going on, but also an ability to move around while in labour. So then you have the electronic fetal monitoring. So straps are attached to the pregnant person, and it will monitor the fetus heartbeats and contractions via a machine. A midwife will discuss this method before it goes ahead. It does normally occur when there are complications, or maybe there's underlying health condition with the lady that is pregnant or the fetus themselves. Some of these are things again like gestational diabetes, high blood pressure, and just if they found out if the baby's too small or too big. This will be a version of constant monitoring, which means that there's very little movement for the patient once they're in labour, because these will constantly be strapped on and they cannot move while these are on. Telemetry is another way of measuring the fetus and patient's heartbeat and contractions. There's also something called a fetal scalpel electrode. So that just attaches to the fetus's head when in delivery to monitor heart rate. This will be done when the doctor or midwife are worried about the heart rate of the baby and they're just unsure how they'll cope going through birth. And then you've got the intrauterine pressure catheter, which just monitors your contractions as you're going through birth. So a risk assessment will be completed for all patients, just to make sure what the best form of monitoring is for each individual, just due to their needs and their risks, any health conditions they may have. This can always change, as no labour is the same for anyone. And obviously it's a continuous updating risk assessment as well, because things can always happen or go right or go wrong or not expected during labour. If there is a risk to a mother or child, it depends on the type of risk and what the condition is, to what intervention or what change will be need to be made to the birthing plan. It could be that labour is not progressing quick enough and the baby's got stuck while having a natural birth, which then could mean that measures need to go in place where they go in for, say, forceps or a C-section, just to make sure it's safe for both mother and child. So just some conditions. So you've got trisomy. So this is a condition which the baby has 47 chromosomes instead of 46. So this can cause the baby to have a number of different health conditions. It makes the first 3 months of pregnancy much higher risk than normal, as there is a higher rate of miscarriage, as well as after the age of 35. A baby is more at risk of getting trisomy, and some conditions can cause this as well. Unfortunately, not something that can be prevented or cured currently. Another condition is Patus, and this is really rare, and it only happens in 1 in every 4,000 babies that are born. So majority of the babies who have this, they do unfortunately either miscarriage early, are stillborn, or they do die within their first year of birth. This is just due to the severity of the complications that the baby has when they're born. These range from things being like they could be born with one eye or no eyes, a smaller head than normal, a cleft palate, and also in some cases the brain can detach and not attach as it should within a normal baby. The cause of Patus is completely random. is not anything that they've found it's related to currently, and it is caused when the egg is being fertilised by the sperm and the cells do not divide correctly. Has nothing to do with parents, and it's not hereditary. Around the 10 to 14 week mark, parents will be offered this option of having a test done, which is an ultrasound to be performed as well as bloods. When the results come back, if they show a chance the baby is at risk of having this, the mother will have further blood tests to confirm the risk of this occurring, and then finally cells will be taken via a very invasive procedure from the baby just to confirm for certain whether they have this or not. If a child has the condition, the parents will then be tested to see if any further pregnancies are at risk of the same outcome, and they will obviously request permission to take samples so they can research further into the condition in a lab. Another condition that a baby could be born with is Down syndrome. So this is caused by an extra chromosome and can happen to 1 in 1,000 births. It causes things like learning difficulties, heart and digestive conditions, hearing loss, vision loss. A test again will be offered around the 10 to 14 week mark of pregnancy, and again an ultrasound will be performed along with a blood test. The ultrasound will just measure the fluid around the baby's neck along with the results of the blood test and the mother's age, just to create a chance of this occurring. If there is a high risk of Down syndrome, obviously a healthcare professional will be there to discuss this with the parents in depth, and again they may be required to have a more invasive testing procedure just to see what the likelihood of this condition and determining it. And finally there's the Edwards syndrome. Is also known as trisomy 18, as the chromosome 18 has 3 instead of 2. So the condition is extremely rare, and it does mean that if a baby is born with the condition, they do have a very slim chance of living past their first birthday. Anyone can have a baby with this condition. However, the older the mother is, the more at risk they are for getting this. There are 3 different strands of this kind of condition. The first is full Edwards syndrome, and this one means that there is an additional chromosome, and unfortunately most babies with this will not survive past birth. There's mosaic Edwards syndrome, is the version that means that there are much milder conditions, symptoms, effects that will happen, but there is a higher chance that the baby could live all the way up into adulthood. And finally there is partial Edwards syndrome, which means the chromosomes are only partially affected, which means the baby could be born with different conditions including heart and respiratory problems. Like Patterson and Down syndrome, they'll be tested the same way, and they'll continue to have more invasive tests as they go along if detected. So on to the hereditary diseases and fetal anemia. So sickle cell anemia is a disease in which the shape of the cells as well as consistency change, turning them hard and sticky, which means the blood flow does slow down. Some of the symptoms of this, sickle creases or sickle cells collecting together and become painful, and they can also cause organ damage. It can result in them being more likely to be at risk of infections and colds and things like that as well. Another hereditary disease is thalassemia, and this is a condition which the red blood cells are not getting enough oxygen passed through the body. It also makes them very anemic. Many people with this condition will continue to have this throughout their life. Many have had to have blood transfusions as well as medication. The mother will be offered the test before 10 weeks of pregnancy, and if the mother does carry the gene for these conditions, the partner will also be offered this test as well. The initial test itself just involves having a blood test. If this is positive at this point, the father will be offered the test, and if he tests negative, then it means the baby has a less likely chance of having it. If it is found that both of the parents have this, then further testing can be informed performed. This includes a chronic villus sampling, which is a needle through the mother's stomach to take a sample of the placenta cells, or amniocentesis, which will be a needle through the mother's stomach to take a sample of the fluid around the baby. So fetal anemia is a condition in which the baby's blood cell count is very low. This can be caused by a number of different reasons. One of these is the blood type not matching to the mother. An infection that has crossed the placenta maybe, so the baby's ones like herpes or paravirus, and also disorders like Down syndrome can be the cause of the anemia. The ways in which this will be detected is through, again, blood tests, ultrasounds, and they'll be monitored. They'll just monitor the antibodies and the flow of blood. If either of these are abnormal, more tests will obviously be done, and then they'll be monitored continuously throughout the pregnancy. Apologies. Okay, so this one, so the risk factors of miscarriage and how to reduce the risk. The risk factors of a miscarriage are age. So obviously, as the older a person gets getting pregnant, the more risk becomes. So over 30, currently there's 20% chance of miscarriage, and then over the age of 40, that will increase again to around 50% chance. Medical conditions can also be something that need to be taken into consideration when getting pregnant. Things like obesity, diabetes, blood pressure, as well as lifestyle choices like drugs and alcohol and smoking, they all cause risks to a miscarriage. Although these risks are involved, there are many ways in which they can be prevented as well. Key things like stop smoking, stop drinking alcohol, cutting out food that's possibly harmful for the baby, as well as eating healthily, not just to maintain yourself during pregnancy but also the baby as well. In some cases, if an issue can be identified before treatment can be administered, things like Hughes syndrome, which causes blood clots, medication will just be administered, and this hopefully will treat and improve this during the pregnancy. Or in some more serious cases, like a weakened cervix, an operation will need to take place via surgery by putting in stitches to keep this closed. Okay, so the misconceptions of miscarriages, like everything, there are misconceptions to what happens around certain subjects. So especially with miscarriages, there is the misconception that they are rare. Miscarriage is the pregnant person's fault. It's easier to deal with than the loss of a child at birth. The doctors can't lessen the pain. Nobody wants to talk about miscarriage. All these things get thrown about time and time again, and they are complete misconceptions. Doesn't matter who you are, any of these can affect you in a certain way. Miscarriage can happen to anyone. It's not easy having one either. The doctors and healthcare professionals are there to aid and assist you mentally, also physically. They are available to you. Okay. So when termination may be considered and the process. So pregnancy termination is a very big decision for anyone. Some mothers have already made this decision, and it will come down to the choice of the mother if they wish this to happen, and also who they wish to tell this about. Everyone has their own set of circumstances in which this would become a choice. Anything from family, health conditions, and in more severe cases in which the mother has been harmed. The NHS do provide this for free, and a referral can be done via abortion providers, GPs or sexual clinics. There is also the option of private practitioners, but there will be a cost occurring for these. Most terminations are performed before 10 weeks as there's less risk in this time. However, in some cases, there are circumstances in which the mother has to decide to have one after 24 weeks if the termination is a better option for themselves and the child, as there could be a risk of high life or the severity of the learning disability for the child could be reasons why. There are two ways in which termination can be carried out. The first one is a medical abortion, which consists of 2 tablets being taken within a 48-hour period. And this will just start the process of the abortion, and the body will later just expel the fetus from the body. The second termination method is surgical method, but that depends on how far along you are. There are 2 methods to this as well. So up to 14 weeks is a vacuum suction procedure, which will be performed, and this is just where a tube is inserted into the vagina and sucking out the pregnancy, and will normally take up to about 10 minutes to complete. The other method is after 14 weeks. So this is just dilation and evacuation will be performed using forceps and removing the pregnancy. This will normally happen while a patient is sedated. So with both procedures, in most cases, you'll be able to go home the same day after close observation for a few hours just to check that the mother is okay. Once this has occurred, the patient may experience pain and bleeding, and they'll need painkillers and to wear sanitary towels until this slows down. Thank you.